her expertise as a lab director to help microbiologists understand the clinical impact of their work. Mandrea also enjoys training new microbiologists and raising awareness about the public health and clinical microbiology profession through outreach activities. Outside of the lab, you can find Mandrea hanging out with her cat, spending time outdoors at dance classes or reading. So without further ado, Dr. Mandrea Howard will present STI testing recommendations.
Yeah. Oh, thank you. Thank you for attending. So STIs is one of my favorite topics recently. We've brought a lot of tests on lately that have related to it. So I'll get right into it. These are my disclosures. I'm on the Speakers Bureau for Cepheid, but I don't think I mentioned any specific platforms in my talk today. So we'll get right into it. So these are the current CDC recommendations for STI screening. So a lot of them target specifically women, but in general, for chlamydia, gonorrhea, you're going to want to test, they say annually and with every new partner, but most people who get new infections are between the age of 15 and 24. So really targeting men and women under the age of 24, and then women above 25 that are at increased risk. And so increased risks means high-risk sexual behavior like multiple sex partners, inconsistent condom use, or transitional sex. There's also some extragenital sites that you can test for throat and rectal. And for not men who have sex with men, it's considered based on reported behavior. And then for men who have sex with men, it's actually recommended to test all three sites. And then syphilis is at least one screening throughout your lifetime for people at increased risk. And then there's universal screening for pregnant women. There was a new ACOG guidance that went out last year. HIV, people should be screened at least once during their lifetime. And then trichomonas doesn't really have any screening recommendations, mostly considered screening for women in high risk or high prevalence settings, so like STI clinics and if they're incarcerated. And then there's some more stringent recommendations for men who have sex with men. They're screened more frequently. So like basically annually if sexually active for all of the different STIs. And then there are some recommendations for transgendered and people of gender diverse persons. And again, more frequent screening than than adolescents or adults. So I'm just going to quickly talk about trichomonas. We had just recently brought this test on one of our platforms because they had just got approved for male urine. So this is something that isn't routinely screened for, but it is the most prevalent non-viral STI worldwide. So most of your symptoms are going to be, for women, it's vaginal inflammation and discharge, or strawberry cervix is what they call it. And then for men, if you're symptomatic, you'll have urethritis. And so the diagnostics for this are wet mount, which we don't do in my lab. It's a point of care testing typically, or it can be done in the lab. We do nucleic acid amplification testing. So your specimen sources for that are now male, female and male urine, otherwise cervical and vaginal swabs, and then sometimes Pap specimens as well. It's typically performed on women who are seeking vaginal care, and it's for at least the NAT testing, it's in a panel. So you're looking for BV targets and then candidiasis as well. So it's usually incidental finding in that case. But since most people are asymptomatic and don't know they have it, and if you're sleeping with the same partner who might have given it to you the first time, there are a lot of repeat and persistent infections. So it is recommended to rescreen people 3 months post-treatment, which is metronidazole, to show that it's cleared. And then concurrent partner treatment is also very important to prevent reinfection. So we're going to spend some time talking about chlamydia and gonorrhea testing. So these are the most frequent bacterial STIs reported in the US, specifically chlamydia. Again, with most STIs, symptoms people are asymptomatic, so they don't know they have it, which is why we have such high levels of STI infections each year. For women, if you do have symptoms, it's usually cervicitis, and it can have complications like pelvic inflammatory disease if left untreated, and then complications during pregnancy. And then men will have urethritis and epididymitis. And then these are usually tested together because they have similar symptomology, and co-infections can also occur. So The specimen types are going to be vaginal, either patient collected or clinician collected, urethral, cervical swabs, or urine specimens. And then for extragenital screening, you can use throat and rectal swabs. So there has been an increase in antimicrobial resistance to Neisseria gonorrhea. So right now, ceftriaxone is the last first-line drug available. And so if you have failure to that, then it would warrant a culture-based follow-up. But most of the time, you're not going to do culture unless you have concern for antimicrobial resistance. So for extragenital screening, it is right now only really recommended for men who have, or at least there are recommendations for men who have sex with men to be screened at basically site of contact. So that'll be throat, rectal, and then urogenital. There's been a lot of studies that have shown that urogenital screening only can miss up to 60% of CT and G infections in this population. Again, most infections are asymptomatic. And then there's been some thought that throat and rectal infections can contribute to antimicrobial resistance or be associated with antimicrobial resistance, although I don't think there's any real data on that. But it might also serve as the reservoir for genital infections. So you can spread from throat to urethral or, urogenital to rectal as well. There's a couple polls in here, but we do test our throat and rectal sites on one of our platforms. We did not validate it on a separate platform we have, but I just wanted to get the feel. Are you guys validated for these sites and do you test for them in your lab, if you know? No?
That's a good question.
Yeah.
What platforms do you use?
So we use the Cepheid for our ED and urgent care because for the micro lab, we're available 24/7. Our cytology lab has the Panther, so they do all of our outpatient, and they did not choose to validate throat and rectal. So if we do get throat and rectal, it comes through the Cepheid if it's collected correctly. Otherwise, it gets sent out to our reference center if it ends up being collected on a Aptima swab. So we only have it on one platform, but not the other. So mostly we see it coming out of the urgent care or out of our comprehensive care, which is one of our STI clinics. So this is a hypothetical question. So actually, this is partially a friend who asked me, but she had a new partner and she had only reported oral intercourse at the time. And so she was asymptomatic, but just wanted to get screened. And so in addition to like, obviously your routine screening for syphilis, HIV, chlamydia, gonorrhea, I guess what other test sites would you consider for chlamydia and gonorrhea testing? So the STI treatment guidelines suggest that vaginal swabs are the better source for women and then urine for men. But I feel like most people could just collect urine. But let's say you could either get a pelvic exam and get your vaginal or cervical collection. You could just do urine, or you could do vaginal with a throat swab because that was a reported behavior, or do all three sites. What would you suggest? Okay, that's not bad. I would actually suggest all of them. So there's been some other studies lately that looked at outside of just men who have sex with men populations, but so this was in Louisiana, which is ranked very high for chlamydia and gonorrhea over the years. And as of 2023, they were first for gonorrhea and second for chlamydia. So they did this study between 2016 and 2019, where they basically brought on routine extragenital screening at their parish health units. And I think by the end of this study, there was like 11 units that they were able to do this in. So they just assessed if they can identify missed or untreated chlamydia gonorrhea cases. And they used sexual history to determine sites of exposure. So due to billing, they only tested 2 sites. And they gave priorities. So if someone said, oh, I do, get receptive anal sex or oral sex, then they prioritize the rectal sites over if they reported all 3 sites, they prioritize the rectal sites over the throat sites. And so what they found was that there was a decent prevalence of chlamydia and gonorrhea in both throat and rectal sites. But if they had only done urogenital screening, they would have missed 7% of chlamydia cases rectally, about 2% of throat chlamydia cases, 3% of rectal gonorrhea, and 3% of oropharyngeal gonorrhea in women. And so they split it by women who have sex with men, women who have sex with women, and women who have sex with men and women. And then in males, obviously the group is mostly men who have sex with men who have the rectal and pharyngeal swabs. They did not collect any rectal swabs in men who have sex with women, which kind of makes sense. But they still found a pretty high prevalence of missed cases if they only tested urogenitally. And so there have been other studies, a handful of different studies. I just kind of picked this one because it was my favorite. But depending on what study you looked at, the prevalence can be anywhere between 2 and 77%, which is insane, or for rectal chlamydia, and then less than 1 to 36%. And so a lot of these were in STI clinics. This one, the Louisiana one, was more in a community-based setting, which I think why their rates are lower. But I mean, most people who are going to STI clinics are the ones who are getting screened. So you will want to make sure that you're capturing these sites. In a lot of these studies, what they highlighted was that when specifically for rectal sites, when they were tested and identified, it was in a lot of people. I think it was like up to like 80% of people who actually didn't report anal sex. So either your patients have bad historians and don't want to admit that they're doing it, or in women specifically, you can kind of have like contiguous spread, based on anatomy. Maybe it's just spreading from your vagina to your rectal, or again, you're just not reporting anal sex. So I support screening all sites, especially if you report sexual behavior in that way. The benefit of treating extragenital sites has mostly been identified in men who have sex with men because it's shown to have a higher risk for HIV acquisition. In women and men, or heterosexual women and men, it's not really well known, but we do know there's a lot of complications in women from chlamydia gonorrhea, untreated chlamydia gonorrhea cases that can lead to PID and things like that, or you could just spread it to your partner that way. So some of the limitations that can prevent, routine screening of these sites is testing availability. If you're the lab that you're sending these specimens to, don't do it. Patient and provider education. So I had a friend that actually came to me where they specifically asked their doctor to test all 3 sites, and they were like, well, you're asymptomatic, so it doesn't, or you don't have any symptoms, so it doesn't matter, or whatever. And so they were just like very upset. And so I actually just told them to go to our STI clinic, because our STI clinics that we have at LGH, they routinely test all 3 sites. Like you come in and they're like, we're going to do throat, rectal, and urine. They don't even ask what you're doing. They just do it routinely, which is useful. And then, what's the additional costs of testing for testing all 3 sites? Did you have a question? I think it's just easier than trying to do a pelvic. Well, I guess you could do patient collected vaginal, but I actually don't know. I did not ask them that, but they just kind of collect all 3, and they actually have. And I don't think any platform is actually approved for self-collected extragenital, but I think wherever they send it must have validated it, because they actually do self-collect for rectal, not for throat, because that one would be quite harder, but they do self-collect for rectal, which is, makes people feel more comfortable than having to get a rectal exam. Okay, so we're going to switch to syphilis real quick. So this is a progressive disease, obviously, that's marked by 4 stages. So if you're exposed, you have an incubation period of up to 90 days. And then primary syphilis is characterized by this chancre, this lesion that usually resolves after a few weeks spontaneously. And most people don't know they have it. Apparently, it's painless, although I look at some of these pictures and I'm like, how is that painless? But that's what they say. And then that goes away. And then your secondary is some like nonspecific symptoms, but usually you'll have secondary lesions. And in both of these stages, you're most infectious, and that's when you can transmit. And then you have your latent stages, and that's just really marked by basically you have positive serologies, but no symptoms. And they kind of split it between early and late latent, and that kind of just depends on if within the last year that you were like negative and then turned positive and don't have symptoms, you're early latent. And then if it's past a year, you're late latent. I don't really know what the difference and how that, matters, but that's how they split the 2 up. And then tertiary, luckily, is rarer now, but that is the final stage. And that usually happens multiple decades after acquisition. And so you can have some other symptoms. Neurosyphilis and ocular syphilis can pretty much happen within any stage of disease. And all of them are treated with penicillin G. And the dose and duration kind of depends on the stage of the disease you have. So last February, the CDC published a laboratory recommendations for syphilis, and this was super timely for my lab at the time because we sent our syphilis testing out, and then we got a bioplex, and so we decided to bring it back in. So we actually do the reverse algorithm, which I'll get into soon. But the response to syphilis is based on testing. You either have your treponema-pallidin specific antibodies, so that's the causative agent of syphilis. So that serology comes out about 2 weeks, and then it persists for a lifetime. And then you have your non-treponema antibodies, which is more like host cell damage, like antigen thing. And that antibodies come out about 2 weeks after the T pallidum antibodies. And then you can actually monitor non-treponema antibodies to look at if treatment has been working or not. So if you've been treated within the year, you can see it. Is there a laser on here? Oh, yeah. You can see it go down and circumvert here. And there's sometimes people who get no treatment and it kind of just gets to these like stagnant levels. So one of the recommendations for when you're doing your non-treponema testing is when you're doing endpoint titers to report it all the way out, so you don't use greater than or less than signals, because you want to have a baseline to let people know this is what your infection is at, and then you want to see a 4-fold decrease to indicate that treatment is working. So for your tests, you have your treponema tests, which are specific to T pallidum. And these are either immunoassays, which are typically automated, which is why we went with the reverse algorithm, because our first step is automated and the RPR is manual. And then you have the T pallidum particle agglutination test, which is kind of the preferred manual test. And your non-treponema test, again, just detects non-specific antigens. So this would be cardiolipin and cholesterol from host cells and other bacteria. And these are really just flocculation tests, either macroscopic, which is your RPR, which you can see here, or microscopic, which is your venereal disease research laboratory test. And that one's usually used to determine neurosyphilis. And then the importance of the RPR, in addition to monitoring treatment, is that because maternal antibodies are passed from mother to baby, if you're concerned about congenital syphilis, you will obviously be positive for T pallidum antibodies, but you want to use the quantitative, sorry, click the wrong button. But you'd want to use the quantitative test to determine the chance of a baby having congenital syphilis. So you would compare the RPR from the mother to the RPR from the baby, and I think it's supposed to be like a 4-fold increase or something like that. And then obviously you'd look at other clinical symptoms as well to determine if it's a probable congenital syphilis case. So the main thing to take away is that you're going to want to use both serological tests, because one alone is not specific enough to tell you, if you're positive. So you have to have 2 tests. And so if you have a reactive test, whichever algorithm you decide to go with, your first reactive test would then have to be confirmed by secondary reactive tests to diagnose syphilis. And then your specimen types are either serum, plasma, or CSF. So there are 2 algorithms. The traditional algorithm is starting with a non-treponema test. And then if that's reactive, you'd follow it with a treponema specific test. So this was kind of traditional because before automated tests came around, the RPR was more cost effective and people could easily start that way to monitor and then follow up with treponema tests. So some of the limitations that there are some biological false positives. So again, it is a host and cell and/or bacterial cell non-specific antigen. So you can have other diseases that can cause false positives, like autoimmune diseases, pregnancies, other spirochetal infections, intravenous drug use, other bacterial infections. And then your reverse sequence algorithm is actually requires 3 tests now in this case. So you'll start with your treponema antibody test. If that's reactive, you'll do a non-treponema test. And then if that's non-reactive, it would suggest that either this first one was a false positive, so you would doubly confirm it with a second treponema test to indicate if it was either previously treated syphilis or a false positive. So the use of this algorithm is shown to be maybe more specific in detecting early or latent phases, and that's because of the way the treponema antibodies come out earlier than the non-treponema antibodies, so you can catch that primary stage Or you can catch that latent stage where your non-tryptophan antibodies might have already just gone down without treatment. And there was a study that showed maybe a higher false positive rate in a low prevalence population, but the difference was like 1% to 0.1%. And I track our monthly false positives, and we have about a 1 to 1.5% false positive rate that comes off of our Bioplex, where it'll be positive on the EIA, and then negative by RPR, and then negative by our TPPA. So ours is around 1%, at least thus far in the last few months that I've checked. So in addition to this coming out and being timely for when I was bringing on laboratory testing, around the same time, there was some changes in guidance for how to test pregnant women. And that mostly comes from this MMRV that came out in 2022 or 2023, that there were missed opportunities for preventing congenital syphilis. And so there were about 3,700 cases of congenital syphilis in 2022, and 88% of them could be attributed to a lack of either timely testing or a inadequate treatment during pregnancy. And so if they were timely tested here, only about 7% of them got adequate treatment, whereas like the rest and all these blues were either not tested, didn't get adequate treatment, or no documented treatment. So that led, the recommendations by the CDC are to, you would test pregnant women at the first prenatal visit, and then more frequently if they're at risk population. But now ACOG, just because there's been such a increased rates of congenital syphilis over the last few years, suggests to just test all women regardless of risk at first prenatal visit, third trimester, and then again at delivery. So that way you can hedge your bets for if you're catching these different infections, and hopefully you would treat them over. So you have 3 different points within the pregnancy to detect possible syphilis infection and hopefully prevent congenital syphilis. So when we brought our syphilis on, our pediatric group was very happy because they were like, we want to start testing 3 times, and we were sending it out. And I think our turnaround rate was like 5 days, and they were just like, we can't keep someone, a pregnant lady in the hospital for 5 days waiting for a result to come back. So now that have it in-house, our turnaround time is 48 hours, which is really great for them. Okay, so now I'm going to hop over to human papillomavirus. So this is a virus that can cause cervical cancer, or been associated to over 90% of cervical cancers. So cervical cancer is a progressive disease, so a lot of that basically has abnormal cells in the cervix. So your indication for precancers are usually the SIN2, SIN3 here plus. But as you can see, there's spontaneous clearance or progression or regression that can happen. So not necessarily having HIV infection means cervical cancer, but having persistent HIV infection can be a risk for cervical cancer. And then the lack of cervical cancer screening, where you're not capturing these precancers, can also be a risk for cervical cancer. So it is preventative by either consistent cervical cancer screening or HPV vaccination, which can have up to 90% preventative or protective against cervical cancer. So the high risk types are listed here, and then the ones that are bolded in purple are the ones that are included in the HPV vaccine. And then there's also 6 and 11, which causes anal genital warts. They're not high risk types that are also included in the vaccine. So right now, our current cervical cancer screening recommendations are in draft recommendations, but if we start with, there's a lot of different groups that you can look at. If we do the United States Preventative Task Force, they say that young people younger than 30 should be every 3 years with cytology, and that's because there's a lot of transient HPV infection in this group. So not necessarily having being positive for HPV indicates having cervical cancer, and a lot of them will clear spontaneously. So in this case, you'd just be looking for abnormal cells and not necessarily HPV. And then ages 30 to 65, you can either screen every 3 years with cytology alone or every 5 years with HPV testing, primary testing, or co-testing. ACOG kind of follows the same thing, except for they suggest every 5 years with high-risk HPV testing, which would be our primary screening. The American Cancer Society only suggests every 5 years with primary HPV screening. And then the World Health Organization also prefers HPV primary screening, where you can either do a screen and treat, so treat if positive, or screen triage and treat, where if you were HPV positive, you would follow by reflex cytology and then treat based on whatever that cytology is. So the current recommendations from the United States Preventative Task Force are under draft right now, and they're basically going to kind of be consistent with the American Cancer Society, where the preferred screening recommendation will be every 5 years with either clinician or patient collected high-risk HPV testing. And so a lot of these changes come from many, many studies over the years where we've seen that HPV primary screening is more sensitive, has a better outcome and protection against cervical cancer than cytology alone or co-testing, and has a high negative predictive value. So you'd have fewer lifetime screenings and then a reduction of additional diagnostic procedures by just using HPV primary screening. So another poll, which screening options do you guys know that you have available? So for us, we don't have a platform that can do primary screening, so we are only doing pap testing or co-testing. Okay. Yeah, that appears to be the main limitation, is that I think right now there's only 3 platforms that are available for primary screening, and they're all relatively new. So getting that infrastructure into labs, although it'd be great for all of us to do primary screening, none of us have the instruments for it. This is just to show again. So I think primary screening in other countries, it is the mainstay in their cervical cancer screening program. So like Australia, Netherlands, Sweden, Denmark, they all only do primary screening, well, prefer to do primary screening. So this was a study of just like what is available in the US and what are people utilizing here. And as you can see that co-testing is mostly utilized. There's only like 3% of labs, at least the labs that were included in this survey, were doing primary screening. And I assume it's instrument availability, and also that guidelines haven't really hit that as a preferred choice yet. And then, the rest are doing cytology alone. So I think that's very consistent with what we're seeing in laboratories as well. So there was this cool paper that we did a ASM Virtual Journal Club on, that came out of New Mexico, that was talking about how HPV primary screening, or basically that we should support HPV primary screening. And so the unique part about New Mexico is they've made cervical cancer screening a reportable disease as of 2026. So all of their reports have to go through this registry. So they have all this data available to look at, kind of like a statewide, population-wide data cohort than other states might have. So what they did is they wanted to look at basically how co-testing compares to cytology testing alone as their use for the support of switching to primary screening. And so they were looking for women aged 30 to 64, because that's the current recommendations for primary screening. And then they mostly were looking at people who had negative cytology, and of those, which one were co-tests, and then which ones ended up getting like follow-up care. So they defined co-testing as a HPV test within 5 days or 28 days of cytology, and not to rule out reflex cytology. And so what they found was that they had a number of, basically, with cytology or with HPV co-test, that you had pretty much the same number of women who got a follow-up diagnostic result, which would be biopsy and colposcopy. But what you see is that in the HPV group, there is a higher level of disease. So in terms of abnormal, you have SEN2 plus and then SEN1, that you had a higher percentage of disease being detected with co-testing than with cytology alone, showing again that HPV, the addition of HPV testing is more sensitive for determining precancers. And then they kind of show the ratio of positivity. And then with all HPV plus, it's a bit higher ratio of positivity and associated with disease than cytology alone. And one of the concerns, at least that I hear from some of our cytology people, is that with HPV testing, is that it's going to miss, high grade cancer that would otherwise be caught by cytology, having cytology available as well. But what this study showed is that if you use cytology alone, you had 26 cancers that were missed versus only 11 that were missed with HPV testing alone. This is a little nuanced though, because by the time you get to cancer, you would have hoped that these people had been screened multiple times before this. So this wouldn't be your like routine screening population. So in your routine screening population, you're not expecting to capture 26 cancers because hopefully you would have caught that in screening. So, I mean, it does support, that HPV is more sensitive, but hopefully these people, by the time they progress to cancer, would have had multiple screenings that we wouldn't be missing these many cancers with a routine screening population. So basically, they just use this to support that if you uptake primary screening and then to restrict cytology to those who are positive as a way to then determine if they need colposcopy or treatment or more invasive things later. So I thought this was important to highlight. So prior to these, so this is a risk management guidelines that came out from the ASCCP in 2019. And prior to this, basically, if you had any abnormal cells on cytology or any high-risk positive HPV, you would go on to get colposcopy. There have been numerous clinical studies that have shown that, like if you base it on the risk of SIN3, which is our pre-cancers and the risk of cancer, that realistically a risk of 4% or higher would be recommended for colposcopy. So in this case, it would really just be if you were HPV 16 or 18 positive. So this would be the guideline you would use for if you were doing primary screening, or you have these low-grade tests with HPV positive, versus if you just have like ascus and you're getting a colposcopy. So you reduce the amount of unnecessary diagnostic procedures following an abnormal cytology or a HPV negative with abnormal cytology, and kind of just really restricting these colposcopies and treatment for the highest risk for having precancers. So hopefully, I don't know how many people have, I thought this was really cool management, because realistically, going from like, as someone who was younger, like having ascus and then colposcopy to just be negative, like colposcopies are not fun to do. So if you could, restrict that for someone who is really just HPV positive or has like more high grade cytology, then that would really, reduce the more harmful diagnostic procedures that you would follow up with. Okay, so with the changing guidelines, there are now a number of assays that are approved for primary screening. So you have the Cobas HPV assay, the BD on Clarity, and the Alinity M. And so of those, just these two, the Cobas and the BD on Clarity, are also approved for self-collection. So there are many countries that use self-collection as their primary screening method, and has shown, increases access, because let's be real, nobody wants to get a pelvic exam. It is not fun. I know many people who do not go get cervical cancer screening because they fear getting, pap smears. And so as a way to hopefully get people to just get a test, having a vaginal swab that can be self-collected can increase access in these groups of people who don't want to go, or, don't have a clinic close to them that they can go to get cervical cancer screening. So there have been some meta-analysis that come out that have shown that self-collected swabs pretty much the performance is as good as clinician-collected cervical specimens, and they have high relative sensitivity and specificity. So for the two assays that are approved, they are only approved in a healthcare setting, which is great. Self-collection is great. But, if you are in a place where you have structural barriers to clinics, then having to go to a clinic to self-collect a swab is still not going to happen. So being able to do self-collection in a remote setting, like the privacy of your own home, would be wonderful. So the two assays that are approved right now are approved for these two collection devices. So this is just a flock swab a Copan flock swab, and then this is called the Evelyn brush. So it's a bristle-like brush where you can collect vaginal cells. So there have been, again, a number of countries that use, they actually just mail like self-collection kits to people and have shown that it increases uptake of cervical cancer screening. And so most of these are coming out of European countries and Australia, but there was a clinical study that came out of Kaiser Permanente, Washington, where they were looking at, strategies to increase cervical cancer screening. And so what they did is they mailed home self-sampling kits. So they were looking at how different interventions increase screening uptake. So their usual care were sending letters, 60 days before screening dates, and then reminders. And then they had the education care where they would send the care package plus just explaining that this is a study to see who wants to be involved in cervical cancer screening. They had the direct mail intervention where they mailed out a self-sampling kit where you had the option to opt out, so you just didn't send it back. And the kit contained a dry flock swab and then a patient label to label it. And then they have the opt-in where they mailed the information sheet with a number and a website, and then they allowed you to order a self-sampling kit. So the way they randomized their groups is that they had those that were due for screening, so who had been previously screened and they were due within the next 3 months. They had those that were overdue for screening, so there was maybe they had co-testing more than 5 years ago or a PAP test more than 3 years ago, and then they had those with unknown screening history that they had no recorded screening. And so they randomized everyone to either the usual care education group, and then for the overdue screening, they did direct mail, and then for the unknown screening history, they did opt-in. I don't know why they didn't do both direct mail and opt-in for this group, but that's not my business. So basically what they found is that in the direct mail group across both due, overdue, that they had increased participation versus the usual care and the education group. So that was their primary outcome, is to see when screening would be completed within 6 months of randomization. And so they had, increased participation, but they also showed that the time to completion was shorter. So for the direct mail, they had anywhere between 28 and 41 days versus the usual care, which was about 2 months to come into clinic and finish screening. And then this is just a visual representation. So you can see that the completion here for the direct mail is higher. And then this is the direct mail for the due for screening, and then the direct mail for the overdue for screening. And then all the middle ones are kind of the same across the board. So one of the concerns that always comes up when people think of at-home collection or self-collection outside of a clinic setting is that people are just not going to show up for follow-up. Like they're just going to be like, oh, I got my answer and I'm going to sit at home with it. So their secondary outcome was to see completion of follow-up. And so as you can see, overall follow-up for most of the groups are pretty much the same. In general, the overall follow-up for the unknown screening group was lower, but this is a group that's already not getting screened, so you kind of wouldn't expect their follow-up to be that high because they're already not completing their recommended screening. But in terms of the ones who were positive for high risk or for HPV 16 or 18, the follow-up for colposcopy was pretty consistent across all the 3 groups. So overall, mailing kits at home is not going to prevent people from getting the recommended follow-up. And if anything, it's like, if you know that you have a thing, you're more likely to go and get, go see your doctor for it than not knowing you have it. So at-home screening is just another way of being like, hey, I'd rather you have a test than not actually get screened at all. One of the things that would be important for at-home screening is that you would need a device that can, be shipped through the mail and not really have to worry about reagents and liquids and things like that spilling. So in a lot of these clinical trials, they actually use dry swabs. So this is a shameless plug for this review that I just published, but we did do a review on the utility of dry swabs for HPV detection. So this was basically just a literature search where we searched dry swabs and HPV and found, I think it was like 40 or so publications, and about half of them were diagnostic comparison studies and the rest were just general feasibility studies. But In all of the studies, they found that, the specimen of choice would be a dry swab for remote collection because it can be shipped without buffer, so there's no leak or biohazard concerns. And then there were a number of different swab types, but like the flock swabs and the brush-like devices were the most used, the most evaluated, and had the best performance. And all of the studies showed, similar to that metadata analysis, that the vaginal specimens transported dry have equivocal diagnostics performance for HPV detection compared to clinician-collected cervical specimens. Some of the studies also were looking at how patients felt about self-collection, and they were highly favorable compared to cervical sampling because obviously ease of use, comfort of sampling, you could kind of do it on your own time. And then there were, again, a concern, but there were high rates of appropriate follow-up for HPV positive results. The one limitation is that there's not a ton of data regarding the analytical performance and stability of these dry swabs, which would be necessary if we wanted to start implementing these in our laboratory validations. So there was one paper that did do an evaluation of some variables, and they were mostly looking at temperature and stability. So they challenged the swabs to temperatures you would see if you were mailing in the winter versus in the summer, and then the general stability of HPV DNA over, I think they did up to 30 days. And that was mostly based on these clinical trials that show that most people return their swabs within 28 days. So in this first figure, what they did was looked at the difference in CT values between provider-collected swabs and self-collected vaginal swabs as a function of the days that the swabs remain dry. And so the main thing to highlight here is that when a self-sample was invalid, and that was usually when the beta globin wasn't detected, the average time of dryness was 27 days. So they then ended up doing a stability study where they had a patient collect 2 dry swabs, one that they tested right away as baseline, and the other one that they let be dry up to 30 days. And what they found was that it was not actually the HPV DNA that went away, it was the beta globin cellularity, so that what caused it to be invalid. So your HPV DNA is quite stable, but if your test is also relying on your beta globin, then it might just be like the cellularity that's available to create more invalids. But since the clinical trials have shown that most people return within 28 days, I think as long as you're getting that return rate between 28 days, then your test can go on to be used. And then the other thing they did, again, was the temperature changes. And so they challenged it to winter-like temperatures and summer-like temperatures. And they saw that HPV remained detectable in most samples after temperature challenge. So there was no significant change in HPV CT, but again, your beta globin amplification might be influenced. So I guess it kind of depends on which test you're using to test this. In this case, they were using the COBOS HPV assay, which I think requires beta globin to be detected for it to be a valid sample. So it would kind of depend on what test you're using in this case. So in good news, there was recently the FDA approved the Teal Wand, which is a sponge-like device for at-home self-collection. So that's good. That was this summer. So now they collect it privacy of your own home. You use this tampon-like device here. I don't know if that's expensive or not, but I guess it's $99 with insurance, or $294. I guess it used to be $499, which is a lot. What I could not find is what lab is actually performing this test. Though I could not find that on the website. So I know you send it off somewhere, they'll mail it to your home with a kit and it has instructions, and then you mail it somewhere. I could not find where that is mailed to. So I wish I knew what lab was actually performing this testing. But it is, one step closer to being able to have at-home collection, which is great. Oops. Okay, so we'll go from one at-home collection to now just general advances in at-home STI. So right now there are about 3 tests that are approved for at-home STI collection. There's an HIV test, which has been available since 2012. There is the first to know syphilis test, which was approved in 2024, and this is a finger stick test that detects T pallidin antibodies. And of course, all of these you would need confirmatory testing for positive results. And then there was the VISB medical women's sexual health test that got marketed authorization in 2025, and this detects chlamydia, gonorrhea, and trichomonas in vaginal swabs. This one is interesting because it's like a powered device, and then you use an app, and it like connects you to like a doctor on your phone. So I don't know actually how much that one would be because it seems very like high tech and fancy. But I'm going to talk a little bit about the syphilis first to know because there was this cool paper that came out earlier this year about the clinical development and performance of this. So there's a couple other syphilis self-tests that are it's syphilis and HIV together that are used in other countries, and those studies have shown that it increases, participation in syphilis testing, specifically in people who have never been tested before. So this one was just looking at the performance of it. So it's an at-home, over-the-counter test. It's bufferless. It's a lateral flow immunoassay, and it only detects treponema antibodies. And this is in whole blood. So you use a finger stick, and it's a capillary device. So it looks like most other immunoassays where you get your control line and your test line, and then if those are positive or negative. So it takes about 40 microliters of blood from a finger stick. So in this study, they used sexually active adults age 18 to 64, and then they had a smaller cohort of expectant mothers greater than 18 years of age, and they were just looking at the performance of this in these two groups. And so what they found is that it had a really good clinical performance compared to either algorithm tests or other just treponema specific antibodies. It had high concordance with the reference laboratory treponema assays, and then it had high sensitivity and specificity for detecting positives compared to the either reverse. They didn't tell me which algorithm they used. They just said a reference algorithm, so it could be reverse or traditional. One note they made is that so obviously this is just a treponema specific antibody, so you would need your RPR, your non-treponema to confirm. But they did make a note to say that they compared the sensitivity of the first to know to the RPR positive samples, and they saw that with increasing RPR titers, which would be indicative of more infectious syphilis, that sensitivity gets higher, so that it would have hand wave of like a better chance of detecting infectious syphilis, even though you can't really say that without doing the RPR. But it also was able to detect all of the known stage syphilis patients, which is good. So again, some limitations and advantages with self-sampling. I am all for self-sampling. I think that we all know our bodies and can sample things ourselves. So it increases participation in screening, especially in under-screened patients. Patient satisfaction is great. And then most of these studies have shown that the accuracy is comparable to standard collection methods. Of course, the fear is always how are we going to link people to care when they have a positive result, especially if they're doing it at home. The laboratory workflow disruptions and instrument availability, like if our instruments are not approved for self-collection, although these ones would be at home. Any regulatory and quality issues, and then financial implications. So how do we bill for it? What's our payment structure? Especially once we get to like the follow-up care portion of it. I guess that's really all I had. So my key takeaways would be syphilis to do universal screening in reproductive age women and pregnant women. You need both serological tests to be measured to have a clear diagnosis for syphilis. Support of primary HPV screening. Of course, you would need, the proper laboratory infrastructure for that. The use of self-sampling to increase uptake of cervical cancer screening, specifically self-sampling at home, because having to just go to the clinic to collect a swab is quite annoying. And then that all, helps with our access. So we have huge infection or, increasing numbers of infections for STI, and a lot of it just is people aren't getting tested or don't have access to testing. So, self-collection can improve with that. And then, screening these extrageneral sites can also help detect otherwise missed infections to prevent further infections. And that was all I had.
Do you have any questions? Oh, I have two questions, and one of them, I'm not a clinical microbiologist, so be patient with me. When you were saying that they should be pregnant women should be tested 3 times to prevent congenital syphilis. When does the baby actually get syphilis? When it passes through the vagina or through the mother, through the umbilical cord?
I believe it's umbilical cord, and the chances are higher when you have either primary or secondary syphilis. So it also depends on the stage of syphilis that the mother has, but it can be, well, transplacental.
Right, so it does make sense, because it was the idea that you're testing them right before you give birth, that made me think that maybe it was coming somewhere else. Okay, and then the other thing I noticed, and it's because I'm old and wrinkly, we stopped getting tested for HPV when we're after 65.
Yeah, I don't, yes, yes,
You do.
yes, because they said if you've had so many negative tests,
If your test at 65 is negative and you're HPV negative, you don't have to get another PEP again as long as you live.
yeah.
All right. Do we have any questions online? Oh, sorry.
Yeah, that's it.
Respect to syphilis testing. What is your opinion on automated RPR, non-treponema test?
I would love it, but I think the one limitation that I've seen is it doesn't go far enough. Like you can't,
Just for the quantitative.
yeah, it kind of like,
As far as the screen.
oh, yeah, I don't mind it as screening. We just went with the reverse algorithm because that was the instruments we had. We don't have any, but one of our entities within our health system, they do automated RPR. So they do the traditional algorithm through the automated RPR and then follow up with Tripanemo. So kind of just depends on the available platforms. We just didn't have it at the time. But yeah, the main limitation would be the quantitation doesn't go out far enough for me.
No, go ahead, Barry. Oh, okay. Yeah, I think you referenced it right near the end of your presentation, which was very good, by the way.
Thank you.
But one of the problems with the self-collected samples is that, in fact, the FDA just went recently, they put out advisory providing more of these de novo claims for these type of devices in non-clinical settings. But they specify, this is the hang up, they said it can only be used on instrumentation in the laboratory that is already has that claim in their intended use. So you can't even use these samples that are coming in to use it, in the sort of a lab developed test, I guess. So that's some of the drawbacks we have in the laboratory is that they're collecting these samples in non-clinical settings, but it's not in our intended use on our assays to be able to accept those samples. So we have to get that taken care of first before we can really move forward on it.
Yeah, I agree. And it's interesting because these same companies work internationally and they can do it CE marked. And so it's like clearly it works. And it's been used in most screening programs since like 2012. So I don't know. I guess you could do a LDT because there's clearly a lab that is accepting the TIL ones. I don't know where they're going, but they're going somewhere. My friend did buy one and I'm like, send it so I can know where it's going, but she hasn't sent it yet.
I had a question about Ghana, and I wanted to know your opinion about, as a medical director, like, what is the future of doxypep? So I've heard a lot about it recently, and apparently, gonorrhea is just getting stronger and stronger and stronger, and people are misusing it as commonly. So
Yes, I have purposely stayed away from doxypep and learning it, but I do know, yes, that it's used, but I don't know how doxy contributes to the antimicrobial resistance in terms of that. But yes, a lot of misuse there, or being like, oh, I can't get anything because I'm on doxyprep. But I feel like it's more targeted for chlamydia, right? The doxy part of it. Okay, because it's like what, syphilis, gonorrhea, chlamydia.
I mean, not everything, but.
Yeah.
Question back.
What is, like, how are physicians reacting towards like self-collect or even like at-home collection? Because I go into the doctor's office and I tell them I have a urinary tract infection and I still have to pee in a cup and get a lecture about antimicrobial stewardship. And, you know, the culture has to come back before they'll be like, okay, I'll give you an antibiotic at this point. Because yeah, like I went in one time, I was like, I have a bladder infection, and they're like, how do you know? I was like, I'm 30 something years old.